Yes. Well, this is this gentleman. Um, he's a young male. I think he's 47, 48 years old. Um, has had trouble with his left knee for so many years الحقيقة. And had previous surgical intervention. You can see the scars of previous operations, and you see as he flexes his knee, he gets a patellar dislocation. It is totally dislocating out of position. He's an active man, and this is his long-standing X-ray that shows the valgus alignment and the CT scan, and you can observe that he had previous attempt for reconstructing his medial patellofemoral ligament with screw remaining on the medial side. Um, um, can get some views about what to do with this gentleman. Anyone would offer what to do with this gentleman? دكتور طارق تحب تقول حاجة؟ Please go ahead.
Wanted to reconstruct the MPFL in the presence of that valgus deformity, because definitely it will fail if you do whatever you want. If you don't correct the valgus deformity, it will fail. Now I think it came to the end stage arthritis of the knee with that degree of valgus, and the medial ligament is open, the overstretched. Definitely he needs to have a constrained total knee replacement. I will go from the start with CCK, because I cannot trust the medial ligament, and
Sure.
definitely will correct the valgus and the rotational malalignment if it is there, to have a proper patellofemoral access. Yeah.
True. So we're talking about a constrained implant from the beginning, as being said, because you can't trust the ligament balancing with the standard prosthesis. Mike Hirschman, would you comment, please, on how would you reconstruct this case with recurrent patellar dislocation, a previous attempt for reconstruction? Can we have a mic here, please? Can we get the X-ray back, please?
I think it's an interesting case, and definitely the MPFL. So if you have instability in knee extension, then MPFL is a good thing to do. But if you have instability in flexion, the MPFL can't hold it because it's not functioning there. So what I would do is, I think one reason you need to make a workup of this case first. So you need to understand what is the TTTG, how far is it deviated, and as I've shown you in my presentation, is in valgus knees, you very often have a pathological TTTG.
Sure.
And this is the case here. So that's why the patella is actually dislocating. And so in these cases, it's always a matter how do you talk to the patient. Does he want to go for still correction of alignment first? So if you go for an osteotomy and correcting the femoral hypervalgus, and then you can correct the tibial tracking while doing so, or do you go for a total knee directly, and then you would need to go for high constraint. And so in my hands, then I would go for a fully constrained knee, so a rotating hinge knee, because the LCCK is not really holding the MCL. So that's what the Americans always tell you, that you can do an LCCK in an MCL insufficient knee, but that's not the case. So actually it's not holding it. So then you need to go for a constrained knee. That means a rotating hinge knee. That's the other option, and then correcting everything else. But that's a matter of how old is the patient, what does the patient want to do, and what is your aim?
He's
with
47,
this?
47, 49, I think.
Yeah, that's too young. So then I would go for an osteotomy, because you don't want to end up with a rotating hinge knee at that age.
Do you think an osteotomy would relieve this patient's pain and stop his patella being dislocated.
Yeah,
Can we have the X-rays back on the
I
screen,
think
please?
the difference is what you can correct with the osteotomy is you can correct the malalignment and you can correct part of the instability. What you need to do first is you need to get CT or MRI first, but I think it would correct some part of it. You have an the axial view, the patella, the trochlea is
There is
is
axial cuts
acceptable.
at the level
Yeah.
of the tubercle, and it is
So I think if you do
TTG is around 25.
if you do a varization derotational osteotomy in two planes, then it would correct it, yes.
Okay.
But it wouldn't make him pain-free. But at this age, I would accept it and tell him, okay, we need to wait a little bit more because the other option is he gets a total knee, and we do know that the hinge knees are not working so perfectly as we believe. And what is the next option when you revise this hinge knee then?
Okay. Well, I take your point that he's young, but he has advanced arthritis on the lateral compartment as well as the patellofemoral joint. I'm not sure really whether an osteotomy in its own would make him happy and pain-free. Perhaps we can look at the X-ray and say, well, we have corrected the valgus, and we might have an opportunity to correct the rotation as well to improve the patellofemoral joint. But it doesn't mean that he will be pain-free.
Even the medial compartment
on
here, you can see that there is some arthritis even on the medial compartment.
Yeah.
You can see the
it doesn't matter because the symptoms, the question is, do the symptoms come really from the OA or do the symptoms come from the patellar dislocation? And that's the question you need to answer first to make your decision. So if it's coming from OA, you guide it towards more arthroplasty. If it's coming from the dislocation,
yes,
then you guide it towards the osteotomy.
I fully understand your point and appreciate it very much. If this patient's pain is going up and down stairs and bending his knee, perhaps patellofemoral joint is the source of pain or the major source of pain. But if the patient is getting pain in standing or walking on the flat surface, perhaps this is the OA that is causing the majority of pain, and this was the case. I'll show you what I've done because we are running short out of time. Can we have a couple of minutes, please? The president is asking me to finish, so I'll show you what I've done quite quickly, I promise, and then I'll tell it. Because we have studied this patient's patellofemoral joint, and we know that the TTG was very high, and the majority of his pain was result of arthritis. He has got you would need to realign his patella, realign his extensor mechanism, in addition to performing the joint arthroplasty. CCK might not be enough to give the stability necessary, and that's why I opted for an RHK. Went through the lateral approach and preserving the fat pad, as you can see. And then in addition to the lateral approach, I take the fat pad, as you see, so it helps in the closure later on of the having corrected the deformity. And then having gone through the lateral approach and release the extensor mechanism laterally, I'll move on. I performed tibial tubercle extended osteotomy, so I can realign the tibial tubercle and realign the extensor mechanism. And this was the extended osteotomy of the tibial tubercle. Okay, it's a very long osteotomy. We're talking about 9 centimeter, 10 centimeter of length. This is the shape of the trochlea, the lateral condyle is hypoplastic and the trochlea is dysplastic, but this is the shape of the joint. It is an advanced arthritis of the knee joint in addition to habitual dislocation of the patellofemoral joint. 5 degrees of external rotation in the RHK, patellar resurfacing, reattaching the tibial tubercle medially as well as proximal as well to the degree that would maintain the patellofemoral joint centralized and not dislocated. This is a fixation of the tibial tubercle, RHK, short stems, and fully cemented short stub stem into the femoral and tibial sides. And this is the patient 6 months down the line from the surgical procedure. We have restored we have replaced his knee. We have restored the patellofemoral joint, and this is the functional outcome at 6 months down the line. And thank you very much for your attention.